back to when we were in the early days of the pandemic. We were sadly seeing many people dying in long-term care homes, retirement homes. And the province took some action in follow-up to that to create infection prevention control hubs to be these centers of expertise that could help improve the infection control in these congregate settings where we are seeing, unfortunately, so many deaths. Sudbury Public Health Sudbury District was selected to actually house the hub in this local region. And very recently, the province has now decided to make that a permanent program, no longer just something temporarily in place. So I'm pleased to invite Stephanie Zakrocky, who is our manager of the Infection Prevention and Control Program, as well as Bethnam Faroud, who's an IPAC practitioner within that program, to speak about the work that they do. So over to the two of them. Thank you.
Thank you. Michelle, it's the presentation being recorded?
Yes.
Okay. So please go ahead.
Thank you. So to provide a brief overview of the IPAC Hub program storage. Why it was created, how it operates, and the impact it continues to have across congregate living settings in our region. I'll briefly highlight how the IPAC hubs were established. COVID-19 highlighted significant IPAC gaps in congregate living settings, with severe illness, deaths, and repeated outbreaks. In fall 2020, the Ministry of Health established the IPAC hubs, embedded within the public health units or in hospitals to strengthen IPAC capacity. In public health Sudbury districts, the IPAC hub launched in January 2021. In March 2024, the IPAC hubs became a permanent provincial program. While public health Sudbury districts inspection enforcement role continues to be essential and valued, the IPAC hubs continue an additional support layer focused on mentorship, capacity building, practical problem solving, and fostering IPAC culture. Over time, strong and trusting relationships were built, repositioning the IPAC hub as a collaborative partner and resource. Today, the IPAC hubs provide proactive and preventative approach, supporting facilities with long-term IPAC program development, workforce education, and preparedness. Our work to build sustainable IPAC capacity in congregate living settings is guided in 4 principles. Influence without authority, driving improvement through expertise and collaboration and not regulation. Supporting those responsible for IPAC, focusing on those with day-to-day IPAC accountability, and training trainers. Informed by evidence, grounded in provincial standards and best available evidences. Working along to build sustainability, building internal capacity rather than dependency. Over time, our approach has evolved for a do-for model towards a do-with model, emphasizing coaching, partnerships, and shared ownership, while still stepping into more directly when needed. While we continue to meet settings experiencing high staff turnover, our overall focus has been on building sustainable IPAC knowledge and capacity through partnerships. How the hub applies those principles into daily work. In practice, this means translating provincial guidance and available evidences into what actually works on the ground in diverse congregate living environments. Rather than simply sharing guidance documents, we support settings in applying evidence in a way that fits their environment, staffing models, and risk profiles. Capacity building is central to everything we do, from preparedness planning to quality improvement. We work alongside settings, not over them, using influence rather than enforcement to support lasting IPAC improvements that align with provincial expectations. This slide highlights the core supports and services provided by the IPAC hub to congregate living facilities we support. Our work is not a one-size-fits-all. The services are needed based on information both by what is setting identifies as their priorities and by what they observe during collaborative work within the facilities. This includes education and training, CLS networking opportunities, IPAC program development, assessments and auditing with feedback, outbreak preparedness, and management support, and ongoing coaching and mentoring. Our focus is always long-term, helping settings move from reactive responses towards strong, sustainable IPAC programs.
So how does this look in our day-to-day work? Some example includes site visit and IPAC assessment. During IPAC assessment, we go to the sites to provide IPAC assessment organization and IPAC assessment to the facility to detect the gaps and to help them to fix the gaps. And also we help them to update the IPAC policy. And we have community of practice to give them educational material and also help them to network for networking. We are contact person to for IPAC question and IPAC concern if they have. We also join outbreak management team to help to support outbreak management. Other project that we have. Behind routine support, and as I discussed in previous slide, the hub leads several initiatives. The first one is policy project. In this policy project, we developed some policy, IPAC policy template for the facility to use for updating the policy and procedure, which is the first initiative that we started. And we developed 32 policy procedure for them that is available in our statement. The other one is IPAC newsletter. The hub developed a bi-monthly IPAC newsletter, and we serve as a communication and knowledge sharing tool. The other one is the IPAC Champion. This is an emerging initiative currently in planning phase. The goal is to build internal IPAC Champion program within the long-term care homes and retirement homes, and then, if successful, expanded to other type of community settings. We also deliver education and networking events and continue to the IPAC Northeastern Ontario conference to strengthen regional capacity. The hub is exploring current culturally appropriate and meaningful approaches to support First Nation communities in implementing IPAC measures in partnership with public health Southway and districts, Indigenous public health team. Setting is support. These services are delivered all setting with support as defined the IPAC operational guide, including long-term care homes, retirement home, other type of congregate living settings such as group homes, shelters for women, and also adult developmental services and something like that. The IPAC Hub is a diverse, multidisciplinary team primarily composed of IPAC practitioners, supported by an office assistant and a manager. The team member brings a wide range of professional background, including public health inspection, nursing, medicine, and other health specialties, providing a broad range of expertise and experience to effectively support our community partners. The IPAC Hub works collaboratively with other public health Southway and district teams, including control of infectious disease, environmental health, and vaccine preventable disease. These partnerships are complementary and mutually supportive, bringing together enforcement, outbreak preparedness and response, vaccination, environmental health, education to deliver consistent and coordinated IPAC support. The hub are also strengthening collaboration with the Indigenous Public Health team to support culturally and safe IPAC services to First Nation communities. This effort have translated to measurable outputs. To date, the hub provided approximately 530 proactive site visits. As I said to you, during site visit, we perform IPAC organizational IPAC assessment, and also we deliver 120 reactive site visits, help facility to update approximately 270 policies and procedure, and provided about 100 educational in-person or virtual educational session. Additionally, we developed 32 IPAC policy template, released 2 newsletters, and delivered 3 major annual training series. In 2025, during the 3rd annual IPAC training series, the hub provided education to approximately 185 staff who are most responsible for IPAC across a variety of congregate living settings. In 2026, the hub provided 77 targeted services to support the development and the strengthening of IPAC measure and program across congregate living settings. In addition, 36 education, training, coaching, and mentoring opportunities were delivered. They're delivered directly supporting workforce, knowledge, confidence, and consistency in IPAC practices. Together, these efforts contribute to a stronger, more sustainable IPAC program and increased capacity across the homes. This slide highlights the scale of outbreak-related support provided in current respiratory season. A total of 382 supports and services were delivered to strengthen outbreak preparedness across settings, helping ensure readiness, timely response, and system coordination. In addition, 328 supports and services focus on implementation of outbreak measures, supporting settings to apply required IPAC action consistently and effectively during outbreak situation. I now back to you.
This slide reflects some positive feedbacks we have received from partners regarding the services and supports provided by the IPAC Hub. Feedback consistently highlights the Hub's responsiveness, clarity of guidance, and the value of having timely, practical IPAC support tailored to the individual settings. Thank you. Merci. Language, and don't forget to wash your hands. If you have any questions, we'll...
Thank you for the presentation and the detailed synopsis. Is there any questions from board members?
Does anybody else have any?
No?
Thank you very much. Very, very interesting work, I think. I have 2 questions. First of all, you said one of your responsibilities is translating provincial level evidence, right? I'm just curious about that. So how big a task is that? Is that because the information, the evidence isn't prepared adequately? Or, that it's not understandable? Or is it about trying to convert it into, taking the context into consideration?
I think it's all the above.
Okay.
The guidance and the documents are given to us. Last year, as an example, we were given documentation on COVID vaccine uptake, and it was very hard to discern where we stood in our region. We had very low numbers, but my practitioners go into the facilities and they know they talk to the frontline staff, and they know that X number have been vaccinated. So we didn't know whether the problem was the documentation system that they have for recording, or if it was truly vaccine hesitancy. So it's a multifaceted.
So is that something that the province needs to do a better job at then, in terms of setting you folks up for better outcomes?
That's our whole, that's why we go in there, is for education and for better outcomes. I can't speak to whether the province needs to fix that piece of it, but I know that the documentation is a place where they have a hard time. They have a hard time documenting.
So Chair, if I could maybe
Yes,
just
go
build on that, I think there's always an opportunity for everybody to improve, so there's obviously things that the province can do better. I think a challenge for the province is that they're off in Queen's Park and they're not here. They're not talking to the people in the facilities, the staff in the facilities, the administrators, and they don't really have that intimate knowledge of what things are like on the ground. And, what things are like on the ground in Sudbury is going to be very different than what it's like in Chapleau, which is going to be very different than what it's like in Ottawa, or very different than like it's in Windsor. So it is also a complex problem for them to solve it. So I think they do, I think, their best that they can. Obviously, obvious opportunity for them to try and do better. But we really then are the ones on the ground who understand what's happening on the ground and the variation within our region, are able to then translate what they've produced to something that's much more actionable for them.
Okay, thank you. One more question.
Yeah, go ahead.
So do you envision that IPAC is something that's gonna go on forever, or is there some kind of sunset criteria in mind? Like, how will you know when you've been successful and that the program has become obsolete? I don't know if that makes sense, but.
Obsolete. I'm hoping we don't, very much so. But we're looking at outcomes. That's part of our most recent projects. We're in touch with the FAST team, looking at epidemiology and numbers, just plain numbers on how, but it's subjective. A lot of things are when people get sick, or if they don't get sick, is it because of the IPAC hub, or is it because of the education facilities? There's lots of steps and lots of processes to this. So we're trying to find best ways to get our data. But if it ends, what your question is, if it will be sunsetted, that I don't know.
Well, it's just having worked for the government, I've seen lots of, one manager put it this way, and I don't think this is the case here, but lots of takeoffs, not too many successful landings, right? So a lot of initiatives are put in motion, and I'm not suggesting that this is necessarily one, but it's just, and I don't see it. I mean, I see the need growing with an aging population, obviously, but anyway, sorry.
Sure. So Stephanie would like to see the hub last forever. I'm actually more of the idea that in an ideal world that it would eventually sunset and no longer be needed, but I agree with Stephanie that I don't think that's likely to occur. As long as we have infections, we're going to have people at risk. We're going to need infection control as one of the steps by which we try and keep people safe. And I think it's unlikely we're going to completely wipe out all infections. Sadly, we do see new infections are coming on the scene. Of course, COVID-19, the most famous one of those that did. And so part of the role of the hub is its work may change over time, but there will always be probably new work that comes online. And a lot of what they're doing is about influencing the behavior of the staff who work in these facilities. And those staff aren't the same people from year to year. There's sadly a lot of turnover in these facilities. So there's always a process of trying to get people back up to the skill that we previously had them, and then people change, and you're always trying to rebuild that. We've talked in the past at this board about, working upstream versus downstream, and ideally in public health, we're trying to work upstream, and working upstream would be getting rid of infections in the first place, or creating vaccines so everybody's protected from infections in that level. The IPAC hub, I'd say, is something that we do more downstream because we haven't perfected the upstream work. And perhaps there will be a day where we've, done better work upstream and we found new ways to stop infections, and there'll be less work for the IPAC hub. But I think as long as we have humans and as long as we have infections, we're probably going to need an IPAC hub.
It's almost more of a reactive initiative than a proactive. Thank you very much.
Thanks for the question, Paul, and thanks for the answers. Go ahead now.
Through you, Mr. Chair. In my head, I understand how you would work with a long-term facility if there's, for example, a respiratory outbreak, or even hopefully before the respiratory outbreak, as we were saying, you're meeting with them and training and providing resources. What would that look like for a long-term care facility that is tied to a hospital that already has an IPAC person?
There's different parts in our funding model, and that is one place where we don't typically go in.
Okay,
As long as the long-term care facility has their IPAC staff, our staff won't go into that facility
okay,
unless there's an issue and we're asked to go.
okay.
But it's been very minimal times that we've had that.
Thank you.
Hope I answered your question. Okay. I don't see any. Oh, Natalie, go ahead, Natalie. Fine.
Thank you, Chair, and through you. I'm just wondering if you can just take me through like what your role is specifically on the site visit. Are you looking for, compliance? Are you looking to offer best practices? And if another IPAC person at like a long-term care, even if it's, city owned or if it's privately owned long-term care facility, if they're not following certain protocols, is that your role to then shut them down? Like, do you have that ability? Like, what does that process look like to improve things to prevent outbreaks? Or if there was an outbreak, like, what is your role in, like, do you oversee them? Do you supersede them? Like, I'm just kind of wondering if you can kind of break that down a little bit better. Thank you.
Would you like Benham to speak to like a proactive or a reactive visit? Would that help?
And give us
Yes.
a no.
Yeah.
So when there is no outbreak, we contact the homes, we go inside the home, we provide educational or something like that to the staff to increase their knowledge and also to have educational material for them to help them to improve their IPAC practices. So we have different venue to affect to have effect on their knowledge and also their practices. It is not when they are not in the outbreak. During outbreak, we go there to see what happens inside and what gaps may put the safety and health of people under danger. So this is what we do. In reactive, when they ask us to go there, proactive, we contact them, we try to communicate with them, we try to have a linkage with them, and then they trust us as a resource for knowledge dissemination, for evidence-based material dissemination, and helping them to improve staff knowledge and behavior. This is what is between reactive and proactive.
Mr. Sheriff, and maybe I'll just add on a little bit to the second part of the board members' questions. I think what's a little bit tricky here is that there's kind of two initiatives that are happening. We've heard about the IPAC Hub today, which is really a more proactive, supportive effort, but there's also a regime of inspections that are done for these facilities as well. Sometimes they're done by public health, sometimes they're done, for example, by the Retirement Home Authority, sometimes they're done by other agencies, but there's this full inspection regime that occurs. And they're two separate things. IPAC hubs don't necessarily exist in public health. The province went through every community and looked around and suitable all the different players and decided where is best placed. And in this community, decided it made sense in public health. But for example, in Hamilton, I know it went into the hospital. In other communities, it might be with another non-governmental organization. So that does create a little bit more confusion because we are doing the inspections of some of these facilities in public health, but also the proactive support in public health. So on the inspection side, with long-term care homes, where we go in and do the inspections and we're part of the regulatory authority, we go into the homes, we have a checklist, we go through, make sure they're doing everything correctly. If they're not doing something correctly, they're basically required to make that improvement in a very short order, usually 24 hours, and we come back and validate that. And ultimately, if they were completely non-compliant and not improving things, and we thought there was a safety for the residents to be there, we could theoretically shut them down. But that would be a very extreme scenario. Long-term care homes generally are trying to do a good job for the residents, and they almost always fix their problems very quickly. Where the IPAC hub, though, is it's not coming in to do inspections. It is there as a support and resource. So long-term care homes, they're working on, they know, trying to be proactive and make sure that the residents are safe, and they realize we have some policies that we want to develop in this area, but we don't really feel we have the expertise. They'll reach out to someone like Bethlehem to come and help them out with that. Or they might feel that, we've just got a whole bunch of new staff on, we need to help them with training, we're gonna do some training internally, but we'd like to have someone with real expertise to come in and act Bethlehem come in. Or, we have our inspections, we're likely gonna have coming up and lots of turnovers happen and we've changed some of our processes. We'd like someone to come in and just kind of give us a look of, how are we doing with these new processes? And Bethlehem would come in and kind of do something similar to what an inspector would do, but it would be fully, voluntary, it would be educational, it would not be punitive, but it would give the home a chance to then improve their practices before the inspector comes in from the public health side or the retirement home regulatory or whoever the regulatory authority is to do that inspection. So hopefully that clarifies a little bit the two different sides. There's an enforcement side, but there's also the supportive side, and the IPAC hub here is really the supportive side.
Does that answer your question, Natalie?
Yes, thank you so much for that added context, Dr. Hershey. That's very helpful.
Thank you. Is there any other questions from other board members? Hearing and seeing none. Thank you both for the presentation and the detailed report.
Thank you.